Good day, I am Ricame Gatchalian from 3rd year, Block 2, and today I'll be performing suctioning a tracheostomy tube or endotracheal tube. But first of all, I want you to know that all items in this video are highly improvised. First, we need to assess the patient. This is to identify and observe for complications and to know if the client has labor difficulty in breathing. Note the client's ability or inability to remove the secretions through coughing. This is to know how much pressure will be put from the suctioning, and evaluate the saturation levels of the oxygen, as oxygen is tightly monitored to prevent hypoxemia. Introduce yourself and verify the client's identity. Checking identification ensures client safety through concept of correct procedure for correct client. Explain to the client what you are going to do, why it's necessary, and how the client can cooperate. By explaining the procedure to the client, it may lessen the anxiety and encourage cooperation with the procedure. Lower the side rates if not contraindicated because of health. Place the client in a semi-Fowler's position. Lower the side rates to have access to the patient. A semi-Fowler's position helps to prevent aspiration of secretions, and if necessary, provide analgesia before suctioning. Analgesia provides pain relief for client. Secure additional personnel to assist with the self-inflating manual resuscitation valve device to provide hyperoxygenation if utilized. This is because, as much as possible, 2 hands are necessary to inflate the manual resuscitation valve device. If the client has been suctioned previously, review the documentation of the procedure. This information helps for the nurse preparation in physiologic and psychologic impact of suctioning to the patient. Next is we assemble the equipment. We have the resuscitation bag connected to 100% oxygen, sterile towel, equipment for suctioning, goggles and mask, gown if necessary, sterile gloves, and you can have your moisture-resistant bag. Perform hand hygiene and observe other appropriate infection control procedures, as this reduces transmission of microorganisms. Perform any procedures that loosen secretions such as postural drainage, percussion, or nebulization. This helps to loosen secretions for easy suctioning. Turn on suction apparatus and set vacuum regulator to 80 to 120 mm of mercury. This ensures right pressure is given to the client, as too much pressure can damage the tracheas. Secure one end of the connecting tube to the suction source and place the other end in a convenient location within reach. This prepares the suction apparatus. Monitor the patient's cardiopulmonary status before, during, and after the suctioning period, and then proceed to step 6 for either an open or closed system. This identifies the signs and symptoms of complications, increased blood pressure, bronchospasms, cardiac dysrhythmias, and more. In open suction technique only, open sterile catheter package on a clean surface with the inside of the wrapping used as a sterile field if present. This prepares catheter and prevents transmission of microorganisms. Depending on manufacturer, set up the sterile solution container or sterile field. Use prefilled solution container or open empty container, taking care not to touch the inside of the container. Fill with approximately 100 ml of sterile normal saline solution or sterile water. This prepares catheter to flush solution. Put on sterile gloves. Put on your goggles, mask, and gown if necessary. This prevents contamination of the open sterile suction catheter. Pick up suction catheter with care to avoid touching non-sterile surfaces. With the non-dominant hand, pick up the connecting tubing and secure the suction catheter to the connecting tubing. This maintains catheter sterility, connects the suction catheter and connecting tubing. Check equipment for proper functioning by suctioning a small amount of sterile solution from the container. This ensures equipment function. For closed suction technique, connect the suction tubing to the closed system suction port or unlock the thumb valve according to manufacturer's guidelines. This readies the suction set up for suctioning. Hyperoxygenate the patient for at least 30 seconds with one of the following three methods. Press the suction hyperoxygenation button on the ventilator with the non-dominant hand, or increase the baseline fixed oxygen level on the mechanical ventilator. This prevents decrease in arterial oxygen level during the suctioning procedure. Or disconnect the ventilator or gas delivery tubing from the end of the endotracheal or tracheostomy tube. Attach the self-inflating manual resuscitation valve device. This verifies that 100% oxygen is delivered, where some models of manual resuscitation valve entrains room air and delivers less oxygen. Remove the ventilator circuit or self-inflating manual resuscitation valve device with the non-dominant hand. With the control vent of the suction catheter open to air, gently but quickly insert the catheter with the dominant hand into the artificial airway until resistance is met. Then pull back 1 to 2 cm before applying suction. Suction should be applied as needed to remove secretions and of as short time as possible to minimize decreases in arterial oxygen levels. Place the non-dominant thumb over the control vent of the suction catheter to apply continuous or intermittent suction. In closed suction technique, place and maintain the catheter between the dominant thumb and forefinger as you completely withdraw the catheter for less than or equal to 10 seconds into the sterile catheter sleeve. This decreases in arterial oxygen levels during suctioning, so it must be kept a minimum with brief suction periods. Hyperoxygenate for 30 seconds as described in step 7. This prevents decrease in arterial oxygen level during the suctioning procedure. 1 or 2 more passes of the suction catheter as delineated in steps 8 and 9 will be performed if secretions remain in the airway and the patient is tolerating the procedure. Provide 30 seconds of hyperoxygenation before and after each pass of the suction catheter. Time and number of suctioning should be based on the number of secretions and the assessment done to prevent possible complications for trauma to patients. If the patient does not tolerate suctioning despite hyperoxygenation, try different steps. Use of a different suctioning technique may be physiologically less demanding. Ensure that 100% oxygen is being delivered. Maintain PEEP during suctioning. Check that the PEEP valve is attached properly to the self-inflating manual resuscitation valve device with use of that method for hyperoxygenation. Maintenance of PEEP prevents collapse of alveoli during suctioning. You may also switch to another method of suctioning such as the closed suctioning technique because other methods of suctioning may be more effective and safer for the patient. Allow longer recovery intervals between suction passes. It allows the patient to regain prior oxygenation levels. Hyperventilation should only be used if the patient does not tolerate suctioning with hyperoxygenation alone. When the airway has been cleared adequately of secretions, perform oropharyngeal suctioning. The suctioning of the oropharyngeal area may enhance patient comfort and should be part of an oral hygiene program. In open suction technique, rinse the catheter and suction the unused sterile solution until tubing is clear. In closed suction technique, instill sterile saline or water solution into side port of inlet suction catheter, taking care not to lavage down endotracheal tube while applying continuous suction until catheter is clear. Rinsing removes buildups of secretions in the connecting tubing and with closed suction catheter system in the inline suction catheter. In open suction technique only, on completion of upper airway suctioning, wrap the catheter around the dominant hand. Pull glove off inside out. The catheter remains in glove. Pull off another glove in same fashion and discard. Then turn off suction device. This reduces transmission of microorganisms. Suction collecting tubing and canisters may remain in use for multiple suctioning episodes. Devices that are not in direct contact with the lower airways have not been shown to increase infection risk. Remove PPE and discard used supplies. Proper disposal reduces the risk of transmitting microorganisms. Assist the client to a comfortable, safe position that aids breathing. Positioning the patient may promote lung expansion and provides client comfort and safety. Then put the side ribs up. Record the suctioning, including the amount and description of suction returns and any other relevant assessments. Accurate and timely documentation and reporting promote patient safety.